Today we're talking about atelectasis, one of the most common pulmonary disorders you'll encounter in practice. Atelectasis simply means the closure or collapse of alveoli, those tiny air sacs in the lungs that are essential for oxygen exchange. Introduction and overview. Inflammatory pulmonary disorders range from common conditions like atelectasis to less common ones such as aspiration or sarcoidosis. Infectious pulmonary disorders like pneumonia, tuberculosis, and lung abscesses are also major contributors to illness and death. But for today's lecture, we'll focus closely on atelectasis. Atelectasis is very common, often spotted on chest x-rays. It can be acute or chronic, ranging from tiny areas of collapse, called microatelectasis, to large areas like a whole lobe, called macroatelectasis. The most common scenario is acute atelectasis, especially after thoracic or abdominal surgery, or in patients who are immobilized and breathing shallowly. Excess mucus or secretions can also block airflow and collapse alveoli. In patients with cancer, a tumor may compress or obstruct the airway, leading to a more insidious, slower onset form known as obstructive atelectasis. Pathophysiology. Atelectasis can be classified as obstructive or non-obstructive. Obstructive atelectasis is the most common type. A blockage, like a mucus plug, tumor, or foreign body, prevents air from reaching the alveoli. The trapped air inside gets absorbed into the bloodstream, leaving the alveoli airless and collapsed. Non-obstructive atelectasis happens when ventilation is reduced, often from shallow breathing, pain, prolonged supine positioning, or neuromuscular disorders. Other causes include pleural effusion, pneumothorax, hemothorax, tumors in the thorax, or even an elevated diaphragm compressing lung tissue. Risk factors. Postoperative patients are at the highest risk because of anesthesia, pain, abdominal distension, or reluctance to cough. Being bedridden or having impaired cough mechanisms also increase risk. Clinical manifestations. The onset of atelectasis is often insidious, meaning slow and subtle. Patients may develop dyspnea, cough, and sputum production. In acute atelectasis affecting a large portion of the lung, you may see marked respiratory distress, tachypnea and tachycardia, pleural pain, central cyanosis, a bluish hue that's a late sign of low oxygen. Patients often find it harder to breathe lying flat, and they may appear restless or anxious. In chronic atelectasis, symptoms are similar, but the collapsed lung tissue predisposes patients to infection, so signs of pneumonia may also be present. Assessment and diagnostics. Clinically significant atelectasis usually shows up as increased work of breathing and hypoxemia. On exam, you may hear decreased breath sounds and crackles over the affected area. A chest x-ray often reveals patchy infiltrates or consolidated areas, sometimes before symptoms even appear. Pulse oximetry may show an oxygen saturation under 90%, and arterial blood gases may reveal a low PaO2. Key nursing alert. Tachypnea, dyspnea, and hypoxemia are hallmark signs of severity. Prevention strategies. The best treatment is prevention. Nursing measures include frequent turning, early mobilization out of bed, voluntary deep breathing exercises at least every 2 hours, use of incentive spirometry. Incentive spirometry provides visual feedback as the patient inhales deeply, encouraging lung expansion and preventing collapse. There are 2 main types. Volume type. The tidal volume is set, the patient inhales deeply, holds their breath for about 3 seconds, then exhales slowly. Flow type. Little balls rise with the force of inhalation. The longer and higher they stay suspended, the better the effort. Education and reinforcement are key. Patients should perform about 10 breaths every waking hour with the spirometer. Secretion management is also critical. This may involve coughing techniques, suctioning, aerosol nebulizer treatments, chest physiotherapy, and sometimes bronchoscopy to remove blockages. Management. The primary goal of treatment is to improve ventilation and remove secretions. First-line strategies are the same as prevention: early ambulation, turning, deep breathing, coughing, and incentive spirometry. Many hospitals now use the ICOP program, which stands for I, incentive spirometry, C, coughing and deep breathing, O, oral care twice daily, U, understanding, meaning patient and staff education, G, getting out of bed at least 3 times daily, H, head of bed elevation. If the patient doesn't improve with these basic interventions, advanced treatments may be required. These include positive end expiratory pressure, PEEP, continuous positive airway pressure, CPAP, bronchoscopy to physically remove secretions. If compression is the cause, treatment may include thoracentesis for fluid, chest tube insertion, or addressing tumors with stents, radiation, or surgery. In severe cases, untreated atelectasis can progress to respiratory failure, requiring intubation and mechanical ventilation. Summary. To summarize, atelectasis is a collapse of alveoli, most common after surgery or in immobile patients. It can be obstructive or non-obstructive. Clinical signs include dyspnea, tachypnea, hypoxemia, and decreased breath sounds. Prevention is the cornerstone, with frequent mobilization, incentive spirometry, deep breathing, and secretion management. When prevention isn't enough, advanced interventions like CPAP, bronchoscopy, or chest tube insertion may be needed. Remember, early detection and proactive prevention make all the difference.